this very important report from Dr. Julie Wolfson, UAB Medical Town and COVID-19 outcomes for children with cancer. And before we introduce Dr. Julie, I just wanted to mention to you on the left side of your screen, you'll see your region director. If you're not sure which region you're in, you can go to that website on the COCA website, that link, and find your region. But these names here and emails are the region reps for each of our member camps. And then in our block up there on the top right, check out all the upcoming educational town halls that we've got going for the rest of March, which is almost over, and into April. So now I'm going to turn it over to Dr. Kay Wagner, President.
Hey everyone, thank you so much for joining us. Got a really exciting program for you again tonight. I think all of us would say that kind of a common theme of the past couple of years has been uncertainty. And we know that's certainly true for our campers and our families, especially those of us that help care for them, when you think about how it affects kids with cancer and COVID. Fortunately, there is a resource that's out there that's trying to help us all with the uncertainty during these times. It's called the Pediatric Oncology COVID-19 Case Report. And their stated goal of the report is to describe and disseminate in real time the evolving clinical course of children, adolescents, and young adults who have been diagnosed with cancer and have been infected with the COVID virus or have received a COVID vaccine. They're using 2 national database registries to help clinicians take care of patients during an evolving pandemic. So we are joined tonight by someone with camp experience, both when she was a fellow and now as an attending, Dr. Julie Wolfson, Associate Professor at the University of Alabama at Birmingham, who is one of the team members responsible for this report. And if you didn't know, you can find a link to this report on the COCA website because they were kind enough to share it with us and let us distribute it. So we're excited to have you here tonight, Dr. Wolfson, and I'll turn it over to you.
Well, thank you so much for a very nice introduction. And camp experiences are so, we were talking about before we got on how important they are, as you all know, for obviously for all of our patients. And I'm so grateful for everything that everybody on this call does. I'm hoping that in some way I can help facilitate your all of your conversations moving forward. And I'm happy to help in any way. I think at least what I can do is share with you what we've learned during this long, strange road. So as Dr. Kay shared, I'm at the University of Alabama at Birmingham here at UAB in Birmingham, Alabama, where I was fortunate to meet Jennifer Amundsen early in my time here when I moved here from Los Angeles, but my training was in both Los Angeles and in Boston before that. And I medical school down in Florida. So regionally, I have a little bit of everything is the only reason I'm throwing that in there. So I think it's pretty undeniable that COVID affected all of our lives, initially scientifically and then very realistically. It affected all walks of life. I don't think I have to point out the impact that it has continued to have and the waves that we've gone through. And then we had the advent of vaccination, which has been able to change how we think about this a little bit, which has been nice. But what I wanted to take a minute and kind of put into perspective how I was going to frame the conversation, because, you know, we've been really used to thinking about COVID data. I mean, I live in data and we all really had to kind of wrap our brain around how we were going to think about this. And so the way the CDC and all of our state health departments and city health departments have been sharing data with us has been very focused on community risk and mitigation strategies, right? We've been very used to seeing these either infection rates or cases per 100,000 over a week. This is the CDC from today. I don't think I've seen so many light colors ever. It's so nice. But we've really this is where many of us have been living. And I think so many of us now have that, you know, that quick link to find our data for our county. So they've moved, though, with their recent advent of the COVID community levels, which were introduced in late February. They're now moving to a place where we're incorporating individual risk and really trying to consider what that means for at-risk patients. And so moving from this community risk and mitigation approach to now where we are now, where they're basically saying we're at an individual risk place, so we have to think about at-risk patients differently. There's a little bit of a different bent to how they're guiding things. And again, it's nice to see all of this green where we are right now. I mean, I'm sure there's a lot of people that could take bets on what is going to change over the time to come, but it's nice to be where we are right now. So this is the community levels, and I know that we probably have all seen this, but it takes into account the level of the number of admissions and the proportion of your inpatient beds that are occupied by COVID-19, as well as those cases. And so it's a combination of taking into account the burden on the healthcare system, as well as your current level of COVID in the community, as opposed to just being purely at an infection rate place and thinking about transmission. And this is a way to ostensibly be taking into account where we are with vaccination as well, because that's that healthcare burden. But so when we think about low, I covered it up too quickly. They give a very brief description of what low, medium, and high mean. But in low, they're always going to say at all levels, people can wear masks based on personal preference, informed by personal level of risk, and that people with symptoms of positive test or exposure should wear a mask. But then they start pointing out now, which was a little bit different from before, that while there's a recommendation that the rest of the population can basically be a little bit more liberal if you're immunocompromised or in high risk for severe disease, there's additional recommendations in terms of having a plan for rapid testing and talking to your healthcare provider in terms of whether you're a candidate for treatments. And then also at a community level, communicating with organizations that serve places who are immunocompromised and discussing rapid testing. And this is what that low looks like when I didn't cover it up. And medium, it's very similar, right? This is where really the only focus here that's different from low is that those patients at higher risk have additional recommendations as compared to the rest of the population. And at high risk, in our high community level, then everybody is getting back to the traditional mitigation strategies we've been using. But so taking that into perspective and thinking about, okay, now we're moving to a place where we've been worried, our group has been worried about how do we help communicate potential risk without really, without having vast troves of data. The way in pediatric oncology, we're used to decades of data that can inform what we do. How can we really help our colleagues make these decisions in real time? But now moving into a place where we're really going to be having to think about this more, we're trying to dive in and see where our next steps can be. But I'm going to share with you where we are. So what do we know about COVID in children in AYAs? So back in March 23rd, 2020, and this is an example of a positive use of social media, I'll say. There's a social media group for women in pediatric hematology oncology. And my friend and colleague, Jen Levine, asked if anyone knew of a formal effort to document these COVID-19 cases, because at the time, the New York and New Jersey people were kind of sharing their experience because they were the ones that had some experience. And it was very anecdotal, becoming anecdata. And we thought that we needed to really respond to this community need. And so we established the POCC Report, the Pediatric Oncology COVID-19 Case Report, as a group effort between these New York, New Jersey oncologists, as well as there's some of us there's a couple of us here. There's someone in Texas and someone up in Michigan as well. But really what the goal was is to capture the clinical experience of children in AYAs with cancer and COVID and inform clinical care in real time, as Dr. Kay said. And so we collect no PHI, so no personal health information, which does limit a little bit what we can say in terms of time-based trends, but we collect diagnostic data, COVID-19 data, and sociodemographics. That was March 23rd. We submitted the IRB April 1st, and we decided to do this here. We offered to do it here because UAB has a well-documented history in it in terms of doing a lot of non-therapeutic trials and non-therapeutic studies and outcomes research. And they also have a really strong infectious disease group, and the IRB had put out a message to all investigators saying that any COVID-related research would be prioritized and expedited as fast as possible. So we thought it was at least, if we could get it through anywhere quickly, we were hopeful that that would be here. And my colleague, Emily Johnston, and I are in our research group where we do primarily health services and outcomes research. And so we felt like it was our duty to kind of leverage this research infrastructure for this public health purpose that was too important to ignore. So we had an IRB approval by April 15th, and then our first patient was submitted by April 17th. We actually ran the data a couple of times between then and April 29th because we had 9 patients, and then we had 11, and we had 12. So we had 12 patients and put out our first report on April 29th. Fortunately or unfortunately, as of today, we have 1,850 patients. And we continue to we initially put these reports out every 2 weeks in order to be able to share information as it was changing quickly. We spaced that out to every month because the data were changing a lot less frequently, and we're about to back off to every 2 months because it's changing even less frequently. And we've had some staffing changes too, which is inevitable. This was from when we published our first paper in late October. These were the sites that were participating, but it gives you a sense of the geographic diversity of the sites represented in the data, at least. And these are our sites at present. We have 102 sites that are either open or have submitted cases, 5 sites that are in process, 1 to 243 patients per state, with a mean of 41 and a median of 17 patients per state. The regulatory diversity has been incredible, and I think any of you who work in research would probably not be shocked by this, but we really thought that we had this very clear decision from our IRB that this would be considered research on our end, but that on the other end, this should be definitely exempt, maybe expedited, but definitely exempt. But there were, and they actually felt like no local IRB would be required. It would be a non-human subjects determination in many places too. They didn't even think the expedited would be common, whereas it was exempt at 44%, expedited at 51%, but then 29% required a data use agreement. So that would slow things down for a month or 2, but no local IRB, only at 5%, which was what they thought the most common would be. So I'm going to share some of the data that we have dove into. The report is available online, and we can share the link with you if you don't have it, but it's publicly available on our website, and we update it every, like I said, now every month, soon every 2 months. But these are the more in-depth analyses that we've done. So I'll share with you tonight a little bit about children and young AYAs. So this is the 21 and under. For those of you, I thought that AYAs are kind of my niche, and I had to share a little bit about them, but I thought that there were some camps out there that were also serving some of these AYAs as well. So I'll keep that part brief. But then also patients with ALL in maintenance that are 21 and under, because that is a big proportion of our patients in general, but also those who can get out and do lots of things. Often when we do, talk about work or research that we've done, we save our acknowledgments till the end, but it's really impossible to do that. This has been such an incredibly collaborative effort. This is all of our collaborating authors. So one from each institution that we have been partnering with from our last publication. And I can't even tell you how really inspiring it's been to work with this group of people and to be part of this effort, because we will put out a reminder to say, gosh, sorry to remind you, but we're going to be analyzing data soon, so don't forget to update your patients. And we got 200 new patients in under a week. And you have division chiefs and COGPIs and anyone and everyone entering their own data. I feel awful for the person who was on call over the holidays and was texting me on New Year's Eve to tell me she was updating her data. It's really okay. I'd really like for you to have a night off too. So this is very broadly representative, and we've tried to keep everybody as involved as possible. And so this is just to share that this was the data I'll share with you now represented 917 patients at the time that were 21 and under. And so the median age was 11, and about half, it's about half over, half under, right? And so we had 60% of the patients had an ANC of 500 or more. 20% were relapse refractory. Only 8% had a bone marrow transplant. Comorbidities at almost 35% had at least one comorbidity, and these are the most common. So 4% with trisomy 21, but obesity was the most common. Other combines a lot of things that goes from you know, a mental health condition to endocrinology to et cetera. So what we did first was we compared our patients that had been infected with COVID-19 and had cancer that they've been treated for within the last 12 months. And we compared them to the SEER population to understand, were our cancer patients, was a higher proportion of them, did they look different from the SEER patients, right? So it's relatively similar, about an 11, even though it meets statistical significance in terms of it's being clinically meaningful, it's adjusted about 11 or a little bit over 11. So the yellow is the POCC patients, and there were a slightly smaller proportion of our patients were female. But when you looked at the race and ethnicity, there was a larger proportion of our patients that were Hispanic, as identified by the EMR, but Black was comparable. There were a higher proportion of our patients were publicly insured, and a higher proportion of our patients had hematologic malignancies. So these are the groups that we felt were more likely to become infected with COVID-19. And this was mirroring what we were seeing in the general population at the time too, right? In terms of the symptom profile, so the yellow is all patients, and then red is heme and blue is solid. So the majority of the patients in general were symptomatic, although a larger proportion of the heme patients. Most of them had almost half of them had general symptoms. So these are things like fever, malaise, et cetera. And again, a higher proportion of the heme patients. Again, a higher proportion of the heme patients had respiratory symptoms, so cough, rhinorrhea, et cetera. Comparable proportions of heme and solid tumors had GI symptoms, neurologic symptoms such as confusion, headache, et cetera, loss of taste and smell, and MIS-C. Then we wanted to know how much help did they need to get through this. So there was actually, the majority of patients did not need support, but 31% of them were hospitalized. And this was higher, 36% in the heme patients versus 22% of the solid patients. 9% overall were admitted to the ICU. And again, this was, it didn't meet statistical significance, but this was higher in the heme patients than in the solid tumor patients. And a COVID-related death in 2%. We worked with a lot of the comments to attribute whether it was due to COVID and cancer, or just cancer alone. So 7% required oxygen, a small proportion BiPAP, and mechanical ventilation in 3%. Pressors, dialysis, ECMO in 2%. And then we wanted to know how many patients were having their treatment changed because of the potential impact that could have on their cancer outcomes long term. So almost half overall had their treatment changed, more in the heme than in the solid. The chemotherapy delay due to cytopenias was not different between the two, but it was about 10% overall. But chemotherapy delay not due to cytopenias was about 30%, but that was higher in the heme patients than in the solid patients. And then we had a number of other delays, so BMTs, radiation oncology, radiation treatments, scans, surgeries, et cetera. And then about 16% of them did get some type of COVID-directed therapy, more so in the heme patients, as you can see, 20% as compared to 9% in the solid tumor patients. So then we went and looked at this in a multivariable approach to see really what was predicting hospitalization, ICU admission, and how long those symptoms were lasting. In terms of hospitalizations, the publicly insured patients had a 30% higher risk of being hospitalized, heme patients 60% higher than solid, and patients who had an ANC under 500. The patients with a comorbidity, any comorbidity, were 30% had a higher risk of being hospitalized as well. In terms of the ICU, the old patients who were 11 and over had an 80% higher risk of being hospitalized as compared to the younger kids. And then anybody with a comorbidity was more than twofold higher, had a twofold higher risk of being admitted to the ICU. Their symptoms lasted longer if they were older, and it did not last longer. It was a slightly protective effect if they had a transplant. These unknown ANCs, these appear to be protective. And the reason is because we really required a tight window of an ANC. So we wanted to know within 3 days what their ANC was. And so if they hadn't had counts checked either 3 days before, within 3 days before, or 3 days after, then our presumption is that they're pretty healthy. They're out there, they're not even getting outside labs. Nobody felt strongly enough that they needed to know how they were doing to even send them to the lab. And so then who was getting their treatment changed? So the patients that were more likely to have their treatment changed were Hispanic or Latino, had a hematologic malignancy. The transplant patients were less likely to have their treatment changed. Was it due to a cytopenia, neutropenia, or thrombocytopenia? Yes, in the Hispanic or Latino patients, not due to thrombocytopenia or neutropenia in the heme malignancy patients. So in summary, we saw disparities among the vulnerable groups that were comparable to what was being seen in the general population. We saw that the infection was more likely in the Hispanic and Latino and in the publicly insured, and that Hispanic or Latino patients were more likely to have their treatment changed, even though their rates of hospitalization and ICU admissions were the same. So we thought this was important for pediatric oncologists to use in terms of considering their clinical decisions, in terms of thinking about the risk for severe disease in the patients that were 11 and older, had a lower ANC, had heme malignancies, or had comorbidities, thinking about whether they felt those patients warranted inpatient or outpatient management, and thinking about who warranted therapy modifications, not to say that nobody did, but to really think about it before doing it. And then to consider COVID therapy as an indication as well in terms of monoclonal antibodies and antivirals. Of course, in terms of counseling families on infection risks in the setting of SARS-CoV-2 and on the importance of vaccines. And we also really thought that this was helpful in terms of helping counsel them on activities, right? So school, camp, activities, sports, et cetera. And then considering vaccine prioritization in children under 5 when it becomes available. So then turning to the patients that were 15 to 39, very briefly, what it looked like so these are the symptomatic patients. These are the patients that were hospitalized. These are the patients that required respiratory support. And these are the patients that were admitted to the ICU. So, and this is like 3-year age blocks as you get older. And so as you can see, as they got older, they were less often hospitalized and requiring either respiratory support or the ICU. And it really did start dropping off here in the mid to late 20s. So when we took into consideration what predicted that as well, the Hispanic or Latino patients were had a higher odds of hospitalization, as did heme malignancy patients and patients with what we call high-risk comorbidities. So because this included patients up to 39, we could really pull out the cardiovascular, obesity, and diabetes. And these unknown patients, the unknown ANC patients, again, have a lower odds of hospitalization or ICU because they were doing so well, they didn't even need to have their counts checked. And then in terms of ICU admission, it's similar predictors, except in terms of the Hispanic or Latino patients and the patients with comorbidities. But here you see the patients that are 22 and over, we're so used to them doing so poorly, and we say their outcomes are worse, and the older you get, it's so hard and awful, but they actually had a much lower odds of being admitted to the ICU. In terms of the change in cancer-directed therapy, so this was adjusting for race, payer, diagnosis, whether they'd had a BMT or not, their ANC, and high-risk comorbidities. And we found that this is just looking at age, so 22 to 39 versus 15 to 21, and they had a much higher odds of having any change. This is the one. So these are our odds ratios, and the confidence interval, if it crosses 1, it's not just statistically significant. So really having any change was much higher in the 22 to 39-year-olds. And I think those of us who compare pediatric and adult oncology practices would not be surprised by that, because the adult oncologists are much more apt to slow down and back off. In terms of mortality, there was nearly 7% did die. But this was not statistically significant in terms of the difference, but you can see that the older patients did have a higher proportion of them died of cancer, whereas when you think of the COVID plus cancer, it was higher in the younger patients, the 15 to 21-year-olds. So in summary, among AYAs 15 to 39 that have cancer and COVID-19 infections, there were a higher odds of hospitalization in ICU among the 15 to 21-year-olds as compared to the 22 to 39, amongst the hematologic malignancy patients and patients with high-risk comorbidities, as well as those who were Hispanic or Latino. And there was a higher odds of having their cancer-directed therapy changed among the 22 to 39-year-olds, with similar conclusions in terms of consideration for clinical management and really emphasizing that there's considerations for both treatment and prevention. So is it inpatient, is it outpatient? And monoclonals, antivirals, management of cancer-directed therapy during infection, and then vaccine decisions about school work and activities based on risk. And our question here, of course, that we won't be able to answer at this phase, but we do have patients. We have a subset of sites that have a new IRB they've submitted and are submitting more PHI. And so we'll be able to hopefully drill down into some of these questions, but we want to understand, is hospitalization and ICU admission in this cohort a marker of severe disease? Because there was vaccine uptake earlier on in those older patients, or was it a healthcare system burden because the hospitals were so full of 65-year-olds on vents that there was no room for them and they were just overall healthier, even though they weren't necessarily doing as fantastic. And pediatric oncologists are known for wanting to admit their kids pretty quickly. So this was a sub-analysis led by our colleague Alyssa Khan, who's at St. Joseph's in New Jersey. And so this is, or New York, she'll kill me. So this is children in AYAs with ALL, acute lymphoblastic leukemia, in maintenance therapy. So putting this in perspective, we know ALL is common, right? It's about 20% of our new diagnoses in pediatric oncology. It's the most common cancer in kids. And we know ALL therapy is long. Maintenance therapy is 2 to 3 years. And the therapy is predominantly oral chemotherapy. And so patients with ALL and maintenance are pretty common in our practices. It's highly prevalent. So you've got a common disease with a long treatment. So they represent a large proportion of childhood cancer patients in active treatment. In general, they're less immune suppressed than some of the other therapy regimens. Pre-pandemic, most centers were allowing full participation in regular life, school, camp, social events, activities. So we looked at 292 patients with ALL and maintenance who were 21 or under at the time of their COVID-19 infection. And again, they have to have been within 1 year of having received therapy. The mean age of infection was 10, and so 85% of these were B-ALLs and 95% were in first clinical remission. So in terms of their general symptoms, about almost half of them had fever, respiratory, 34% had cough, 25% had runny nose, some sore throat and shortness of breath, a little bit of GI symptoms in terms of diarrhea, nausea, vomiting, belly pain. 13% had a headache. The other neuro symptoms were really uncommon. Important to note the loss of taste and smell. I stopped trying to pronounce that a while ago because I fumbled every time. But 2% had MISC. So that's a key point to take home too. No deaths. These patients there were no deaths in this cohort, but they did not necessarily do well, as you'll see here. So what was amazing though was 72% did not require any support. 27% hospitalized, 4% in the ICU, 7% oxygen. This mechanical ventilation was 1 patient and pressors was 1 patient. How many of them had their cancer-directed therapy changed? So 57% had their therapy changed, and only 29% of them were due to cytopenias. The majority of those were for less than 2 weeks. If it was held, it was for less than 2 weeks. When we looked at multivariable analyses here, there were none of the characteristics that I've shown you just now had a statistically significant association with changing therapy. There was nothing that actually predicted it. But who was hospitalized? So really, we took into account, again, the same things: age, race, ethnicity, ANC, and whether they had a comorbidity. This is that line at 1, even though I didn't put the numbers on this one. It looked too busy, but now as I look at it, I think I probably need the numbers. But so what's statistically significant here is that those with a lower ANC had a higher odds of hospitalization, as did those with any comorbidity, whereas those unknown ANCs had a lower odds and Black, Asian, or other patients had a lower odds. And for those of you wondering, we did pull out the Black only to make sure that they fit, and they all look the same, and which is why we combined them and kept the Hispanic patients separately. So these are the two characteristics that do predict that hospitalization. So for ALL patients in maintenance, kids receiving ALL maintenance therapy still get sick. So 27% hospitalized, 4% in the ICU, and 2% with MISC. Chemotherapy is delayed in the majority of children. So what we know is that treatment intensity is associated with favorable outcomes. So in other words, drug interruptions are associated with relapse. Risk of hospitalization was increased by low ANCs and comorbidities. And I think it's hard. We wanted to make sure we always put this in perspective with kids as a whole. So when you look at these big reports of kids that don't necessarily have cancer, only 3% are hospitalized as compared to 27%, only 1% in the ICU, and far less than far less than 1% have MISC. So it's not necessarily, I think we all tend to think of, we're treating some really immune suppressed kids, and then we think of these as our kind of healthy, robust kids that we send off to school with a full head of hair. You probably all know this, but COG has been a great resource for our patients in terms of providing something that they are used to seeing and comfortable seeing, with a logo that they're comfortable seeing that speaks to them and isn't just coming from the public health community. So they actually have really great COVID handouts for patients. And so this is for on therapy patients. They have a great handout in terms of taking extra precautions. They do identify that it's a parent or caregiver of a child, teen, or young adult. And they go into some really very nicely worded, kind of COG worded big picture concepts in terms of keeping patients safe. There's also a guide for off therapy patients as well. When you click on this and all you have to do is click on this link. What I think is really important to know though, and I should probably emphasize this on this slide now that I think about it, but you don't need a COG login for any of this. This is on the public COG site. So you can send a patient there. If any of you are not COG members, anybody can click on this and anyone can download them. So I think in summary, we know a lot more than we did in the spring of 2020, but there's still a lot to learn. We're still working on analyzing a bunch of subgroups. We're looking at MISC in specific, and we're looking at the trisomy 21 kids, because we get a lot of questions about, it's tough. There's no real guidelines out there, right? So we get a lot of questions as to how everyone else is managing things, and we tend to just end up being a clearinghouse for that information. So we try to help wherever we can. I think if anyone has any ideas of places we need to go with this, we're always ears. We have some residents and fellows we're trying to give opportunities to, both from our institution, but also institutions around the country, to give them opportunities to work on these things, because a lot of this, we do have a little bit of funding. We're grateful for funding from the Concern Foundation, but a lot of this is blood, sweat, and tears. I think in terms of thanks and our acknowledgments, the POCC Consortium representatives is really who built this, and we couldn't do it without them. Our huge thanks to them. My co-PIs on this are Dr. Emily Johnston, who's here with me, and Dr. Jennifer Levine. And someday it'll be really funny to talk about the fact that Dr. Levine and I both had COVID when we all started doing this thing on social media. Relied on young Dr. Johnston to help us make this happen. Our co-investigators at Texas Children's, David Dickens at Iowa, Alyssa Cohn at St. Joseph's, Carla Schwalm at Bronson, and Archana Sharma at Rutgers. This is our coordinating center and our mentors. And then we have additional contributors that have helped us with the ALL and the AYA sub-analyses. And we have more that are working on the MISC, trisomy 21, and a BMT cohort as well. I'm happy to answer any questions. I tried to leave more time to talk.
Thank you so much for that, Dr. Wolfson. That was amazing to hear all that data summarized so quickly. So we will turn it over to this group. I'm going to start it off with a question, if I might. Have you looked at all at the Native American population? I'm in South Dakota, and that's a group that we seem to be seeing more severe disease in. So I was just curious.
I'm going to turn it back to you and say, if you guys could enter your data, we will look at it.
I was also going to ask if you still wanted some new sites, because I'm
Yes.
kicking myself for not being one yet. So
We are absolutely always, we are still adding new sites. We actually, it was the day you emailed me, we actually heard from 2 other sites the same time. And so we are very much including new sites. Absolutely. We just don't have, we have 1 in the data right now. And so I really can't make, and that patient has 2 ethnicities chosen as well. They're of a mixed ethnicity. So I really can't make any leaps from that. I'm sorry.
okay, no, that's totally fine. And I will be more than happy to get some people involved and become part of your report. So
Thank you.
let's see, there's one question in the chat that says, when do you expect to release the next data?
That's a good question. So we just sent out a report. So the reports that we release are we just sent one out last week. So they're a little bit more basic in that they don't do the multivariable analyses, because we want to make sure that we're really paying attention to those, and to do these every 4 weeks. We don't want to send out messy data. So we do just the descriptive stuff every 4 weeks, but I'll put in the chat actually the website. If I can do that without seeing you.
And actually, I think Ryan has the latest report in the chat already. I was going to see if people want to go take a look.
Oh, thank you.
So,
and that site actually has all the old reports too. We started a vaccine report as well, and so we're also collecting data on patients' experiences with vaccine, but we also added to the report questions regarding whether the patient was vaccinated before they became infected or not. And so we just haven't had enough time with it to be able to run those data. We just need more patients who've had vaccines, but we'll hopefully be able to have some vaccine data for you too. Although I do know the question comes up a lot about PEG allergies and vaccine, and there is a nice, I imagine we've all seen the nice paper out of Toronto Sick Kids now, where they had a case series at least that showed it was safe. And anecdotally, I feel like everyone's doing something similarly.
will you be collecting data about patients that got Evusheld?
We are trying to collect data about patients who get all of the therapies. It's been fascinating to stay up on our form as to what we're calling things, right? So we have to add that now. Actually, if I'm being honest, I'm writing that down, is that we need to add molnupiravir and all of this stuff. Because that's actually the most common question I've been asked recently offline, is how is everyone allocating Evusheld? Because every site's doing it a little differently. And which of our patients do you think should be getting it? And it's hard to say. What we can do is we can give the data to say these are the patients that get the sickest. But I think everyone's making different decisions about that right now. I think that the trisomy 21 patients, if I'm being honest, we haven't finished it yet, but they look like they get pretty stinking sick.
So Dr. Wolfson, it sounds like it may be out of the scope of your research, or you may be working on it. Is there a kind of a general number floating around out there of the percentage of children with cancer who are vaccinated? Because I know a lot of our member camps are considering requiring vaccination for this summer.
I don't know the answer to that. I wish I did. I will say that we only have about 20 sites off the top of my head, 20 or 30 sites that are reporting for vaccine data. So I think it's a really good question. I feel like most of us might not even be able to answer it off the top of our heads, because I feel like it's actually probably a more realistic question to ask the group, right? Like for us to poll our sites and say, what proportion of your patients do you think are vaccinated? I mean, I think if I'm going to represent an area with a lot of vaccine hesitancy, and I'm going to say that we have had a lot of a very favorable vaccine uptake overall in the clinic. I can't say it's universal, but I think I can only imagine that in other parts of the country where vaccine uptake has been more robust, I think it would be even higher. I see Tammy Jenkins has your hand up.
Yeah,
Hi.
thanks. I just wondered if you have been able to collect any data on stratifying by variants once we got to the Delta phase and now the Omicron, and now there's the discussion of BA2. And I know a lot of people can't do the genetic analysis on their samples, but just wondered if you had any data on that.
It's a really good question. And so because the best that we would be able to do that we haven't been able to do yet is to look at it by date. But because we don't collect PHI, we don't even have a date of these infections. We've been kind of hypothesizing based on when people are entering their data. But just like Dr. K was suggesting, they might start entering data too. We also collect it retrospectively. So we do have, again, a subset of about 35 sites that are entering that PHI data. And that's one of our big next steps, is to go in and look at that longitudinally. We've been collaborating with one of my adult colleagues here, 2 offices down, is looking at this big, large data, this N3C collaborative, where they have access to large data, and she's working on the oncology piece. So she's helping us start diving into the pediatric patients in there with cancer, but it's coming. It's just, we don't have it yet.
Thank you.
Mm-hmm. I will say that if I were to hypothesize, though, the patients really, if you put together all 3 groups that we looked at, the 11-year-olds to the 21-year-olds were getting the sickest, right? And I do think from a timeline perspective that because the majority of those patients were put in there, it is very, very reasonable to think that the 22 and over, they were getting vaccinated earlier, right? The vaccine uptake was robust there, whereas those 11 to 21-year-olds, it was just much slower. But I also think that in general, they're getting sicker than the babies as well. They're getting sicker than the young kids. So I think that that's a population in general we need to keep an eye on. And there's a question, Julie, sorry for not being 100% up on this. Last time I looked, Evusheld was only approved down to a certain weight. Are there additional studies ongoing, perhaps in oncology kids, to expand that EUA? It's a really good question. So it's only 40 kilos and 12 years old. Our ID docs here, the infectious disease group here, has been involved in a lot of these trials, and they reached out to us to see if we would be interested. We always partner with them in these studies. And so it does sound like there are studies but they're just about to get started in terms of bringing it down to under 12 and under 40 kilos.
So Julie, our camp is in New Jersey, and last year we were required to take daily temperatures, but this year they've already said they're getting rid of that. And in the traditional camps, that was seen as a victory. But I saw that in your research, 47% of kids that had ALL had fevers. So just kind of in general, do you think that daily temperature taking is a good precaution or not worth the time?
It's a really good question. I feel like the takeaway from that, though, is that the majority of the patients were symptomatic, right, in one way or another. So just because they had a fever doesn't mean they didn't have something. They weren't mutually exclusive. They also had something else. I think that in general, in pediatrics, we've felt that the daily temperature taking is kind of not always done perfectly anyway, so not always ideal. And a lot of, we're doing it with the wand, and it's kind of more of for show sometimes too, to say, look, we're watching you, as opposed to that it really yields great data, right? I mean, I really think that's what they were doing as you walked into the children's hospital for a while. It's like, look, we're checking you, as opposed to really saying that they picked up on fevers. So I don't know that there's anything wrong with stopping it. If someone wanted to continue it, I don't think there's anything wrong with continuing it either, if that's fair. All those patients had a lot of symptoms, not just the fever. And there's another question in the chat. Not sure if this is within your scope, but with the trend moving toward schools and regular summer camps returning to quote unquote normal, do you have thoughts about the level of PPE use, testing, or other adaptations for all populations this summer? Oh, that's a really good question. I mean, it's a really good question. And I think a lot's going to depend on where we are as we head into the summer, right? I mean, I think our hospital just moved to a place where they're not going to screen everybody being admitted. And we've been advocating I'll tell you what we're doing is we're advocating for our patients to be screened because of their risks. So I think that means PPE testing. I think routine testing is always is in terms of using it preventively and preemptively is a great idea. I think we have great access to much less expensive tests than we used to. And it's, I think rapid antigen tests can be really, really helpful in these situations. Although the public health and the ID people sometimes don't agree on the use of rapid antigen tests, I think that they can be really helpful in a public health perspective and in terms of keeping kids and families safe in some of these group environments, if that's help. But I think a lot's going to depend on where we are this summer. I don't envy your position in terms of trying to plan this far in advance because so much can change. But I do think that in terms of PPE use, I think we might be regardless with vaccines, especially, I think we're in a much better place than we were. And I don't disagree with vaccine requirements for these situations when kids will all be together, especially when we know that the vaccines are effective in our patients, but not as effective as they are in healthy, non-immune suppressed patients.
Other questions people have?
This is for basically anybody, I think, any of the docs across the country. One of the things that we've been trying to follow is with the BA2 variant coming as a start, that there has been some case reports of the children with leukemia getting a lot sicker from it than the average oncology population or the average kids. And I just wondered if you have seen any of that data come through while you've been interacting with all these people collecting data, or I haven't seen anything published yet, but I keep hearing case reports.
I mean, I can defer to the anecdotes from around the country as well, but I'll say that in our data, the patients with heme malignancies they're across the board getting sicker, for sure. So I think in each wave, it's been the case, to tell you the truth.
Consistent.
So I wouldn't, it's been pretty consistent that the heme malignancy patients have done worse in each of those. And it's pretty, what I'll say is that as I think through the reports over time, because, when we put them all together, all we have is a lump, but the reports over time, the heme patients have always done worse, regardless of what era we've been in. Mm-hmm.
That's good though. That's helpful because that kind of shows the consistency rather than it being something specifically related to a specific variant. So
it's a good point. And it's the same case in the adult cancer world as well. So I think at least it makes sense.
Okay, thanks.
Dr. Wolfson, just one more question. I know a lot of our camps have considered changing the populations they serve if they used to treat kids on active treatment and now they're considering only remission. Do you know of any research that's been done on kids in remission to kind of guide their decision making?
So I guess it depends on how you're dividing up the population, right? I think that's really why we looked at those ALL and maintenance patients, was because they were considered to be the mellower therapy, right? And often they're included in those remission off therapy patient groups. And so I think we can see that they definitely get sicker. We have our entire group of patients, though, includes patients who are within a year of treatment. So what we did do was we said, does it matter how long ago your treatment was? And it didn't seem to lead to anything. I'll say that was when we had half as many patients as we do now. So I'm tempted to go back and look again, especially because we have the summer coming and everything that we're talking about. But I think that might actually be something that we can dive into for you even quickly, just to see how long ago you got therapy. Does that matter? But I do think that the ALL, those maintenance ALL patients, the reason why we did that was because of what they represent, right? They represent patients in a much mellower phase of therapy, but yet more immune suppressed than we think of. And so there's another group in the chat, question in the chat. Our camp has decided to keep our vaccine mandate for age 12 plus, but to leave it up to family choice for children 5 to 11. In your opinion, is it beneficial to mandate vaccines for children 5 to 11 in a camp setting? I mean, yes, I think so. But I also know that there are a lot of factors that weigh into this decision. I mean, like I said, I had only lived in Massachusetts, California before, and I've been in Alabama through this. It's been fascinating to see all sides of this and to live in the middle of it. I think it would be beneficial, but I do think that I've been involved in advocacy around here as well in general for vaccines and school safety, et cetera, that's related to COVID. And I've been really fascinated to see the difference in terms of the willingness of parents to vaccinate themselves and their older kids, but not their younger kids. But I think that with children with cancer, we can very clearly say they get sicker than kids that don't have cancer. We don't have we're going to look at the NC3 data to try to actually see if we can compare kids with cancer to kids without cancer directly. But what we can do is say in our data set, it looks like this, and in the non-cancer data sets, it looks like this. We haven't been able to statistically compare those, but we think that that's at least a robust enough comparison to be able to say they get sicker than healthy kids. But I'm like, oh, it's a tough, all of them are tough questions.
There was one other question in the chat. Is anyone in Europe tracking pediatric cancer patients in COVID? Might give us some early warning about BA2.
You know, that's a really good question. So St. Jude actually has a more global registry. We both started around the same time and we almost partnered, and then they had a very global focus and we had a very, we were kind of working in parallel. They're doing very good work there, but it's that actually is probably a really good thing to look at in their registry. And I can peek at that because that would be something curious to know. I agree. Theirs is more worldwide than just Europe, but I think could be a really good window into that. You guys have really good questions. Some of them are really.
This group is not afraid to ask the tough questions.
And I appreciate that most of you have to have your camera on.
Well, in the interest of time, we just like to say thank you again so much for joining us tonight, Dr. Wolfson, and sharing this great data. And anyone have one last question? Otherwise, we're going to let her get back to her family.
Thank you, Julie.
Thank you guys so much. Thank you. And seriously, I'm not giving you pressure about putting those patients in there, Dr. K.
Message heard and favor returned. I absolutely will get that done. I promise.
Feel bad for putting you on the spot. Thank you.
No, not at all. I have a great research assistant who's always like, what else can I do? And we're doing some COVID research ourselves. We'll talk.
Awesome. Thank you. Thank you. And if anyone has questions, don't hesitate to reach out to us. Everything, our team email is on that report website, and we back each other up to answer emails. So we're there.
Thank you, Julie. Stay in touch, and we will too. Okay.
Thank you.
As we learn more this summer in our camps, we will.
We would love to hear feedback, because I think everyone asks us, and so we want to be able to help with what everybody's saying. So we would love to hear feedback. Absolutely. And I'm going to look at some of these things I wrote down.
Thank you.
Okay. Thank you, guys.
Julie, I don't know if you saw in the chat, there was someone that Dr. Rafi wanted you to say hello to. You must have some mutual friends.
Oh, Dr. Stagg has been so wonderful. He's been fantastic. I will.
Thanks for being